Good morning. It's my pleasure to chair this keynote talk today that will be given by Olubusayo Akinola on sharing perspectives on community-led interventions in the addiction field in African context with special focus on Nigeria. And I'm very happy to have to learn from African context as well, and the strength of that, the things that they develop in clinical politics, and as well how to work with communities. Dr. Olubusayo Akinola serves as the head of the Social Welfare, Drug Control and Crime Prevention Division at the African Union. She brings significant expertise in designing and implementing multi-component community-based interventions, as well as recovery and social integration strategies for individuals with substance use disorders. Dr. Akinola works closely with civil society organizations to advance grassroots initiatives and advocates for development of age-appropriate, gender-sensitive policies to address substance use challenges that affects women, children, and adolescents across the region of Africa. Her contributions include involvement in various international and national projects focused on drug policy evaluations, and she plays a key role in facilitating interagency collaborations and real-time information exchange with Pan African Epidemiology Network on drug use. Dr. Akinola, the floor is yours. Please, we are very happy to hear from you and from the African context. Thank you.
Thank you, Sophia. Thank you, everyone. As introduced, my name is Akinola Olubusayo. I head the Social Welfare, Drug Control and Crime Prevention Division for the African Union. Before I proceed with my presentation, I would like to ask, apart from those of us that are from Africa, how many of us here have been to Africa before? Oh gosh, I didn't expect this much. Okay. How many of us have been to 5 countries in Africa? At least 5 countries. Wow, this is good. Thank you. And the last question would be, without consulting AI or Google, how many of us know the countries, the number of countries in Africa? Yes, can you try? Almost there. Who else? Okay. So that was the best try. Yeah. So we have 55 countries on the continent of Africa. So now I'll start with my presentation. I'll be looking at the perspectives on community-led interventions in Africa, a comprehensive evaluation of systems, professional attitudes, and regional variation, regional disparities, and also be concentrating on Nigeria. So I don't have any disclosure. And the content of my presentation today, we'll be looking at the continent of Africa and its union, the statistics and trends, which is the Pan African Epidemiology Network on Drug Use Report, the current situation of addiction or drug use or substance use in member states, the survey of substance use disorders treatment facilities and rehabilitation centers in West Africa, and also the Kruskal-Wallis analysis of regional variation in attitude of mental health professionals. And this particular analysis, a survey was conducted in Nigeria, and then the African Union response and AU plan of action, also policy implication. So before I start with my presentation, like I said earlier, we have what we call the African Union. African Union can be synonymous to like European Union, Union of European countries, or United Nations. So the African Union is the union of the 55 countries on the continent of Africa. So it's an intergovernmental organization It was launched in 2002, but as a successor to the Organization of African Unity, which was formed in 1963. The goal is to achieve socio-economic integration, bilateral and multilateral cooperation, and also free movement, to mention a few. So the context now is to look at the population of Africa. We are regarded as one of the most youthful population on the continent in the world because Africa is home to over 1 billion people. And about 475 million of these population are aged 15 to 35 years, and they are referred to as youth according to the African Youth Charter. And almost 60% of this population are below the age of 25 years. According to the 2024 World Drug Report that was released, I know in a month's time we'll be having the 2025 World Drug Report, but it's expected that Africa will be experiencing 40% exponential increase in drug consumption by 2030. And so here at ISAM, we're trying to ensure that we think globally and then we act locally. Our acting locally is our present, but our global thinking is our future. And to ensure that we imbibe all these best practices that has been shared since yesterday and also the ones that will be shared today and tomorrow into our practices to ensure that we have that holistic community that we so dream about. The next slide is the statistics and trend on the reports of the Pan African Epidemiology Network. So just to give a very brief background on Pan African Epidemiology Network, we have this network of focal persons that is being nominated by the ministries of health in the member states and also from drug law enforcement agencies. So for the drug law enforcement agencies, we have the directors of drug law enforcement agency. For this particular data, we collect data on illicit drugs that is being trafficked within and destined also to Europe and other parts of the continent. And also we collect data for the quantities of drug that is being seized, the number of arrests due to drug-related offenses on the continent. So this particular aspect of the network and the data is more on intelligence. So we work, I work closely with Interpol, Europol, Afripol, the World Customs, Universal Postal Union, to mention a few, to be able to gather intelligence. But for the purpose of our addiction, I'll be focusing more on the treatment demand indicator. And this treatment demand indicator, we have also data being collected for treatment. And this data that is being collected for treatment, unfortunately, we are not able to conduct regular or annual household surveys to understand the exact prevalence of drug use in our member states. So what we do is to use treatment demand for those that assess treatment as one of the indicators for drug demand indicator, but just to use it as the proxy indicator to understand the trends and statistics of what is happening in Africa. So the data that we collect is disaggregated in several forms, but I'll be limiting my presentation to age, to gender, occupational status, education, and referral to treatment. For the age disaggregated data on treatment demand indicator, so these are data coming from the entire continent of Africa, just to give us a holistic overview of what is happening on the continent. So for the age disaggregated data of individuals that assess treatment for substance use disorder, we have from 10 to 65 years, as shown on the graph. So this disaggregated data also indicates that the prevalence, we have about 80% treatment entrants are aged 15 to 44 years, and we have 7 in 10 persons that access treatment for substance use disorder on the continent of Africa, aged 15 to 34 years, and are classified as youth. According to the African Youth Charter, we have 4.21% of individuals that access treatment aged 10 to 14 years. It's also important to note that 3 countries in Africa were already reporting children as young as 9 years in treatment for substance use disorder. And that beckons the question, at what age were they actually exposed to the substances for them to have the disorder and be able to access treatment at the age of 9 years? It just shows that early initiation occurs in most of the settings. Then the next disaggregated data on what is going on in terms of treatment demand on the continent of Africa. We have gender and substance use. For gender, we have 1 of 8 persons that access treatment for cannabis use disorder and heroin use disorder is a woman. 1 of 9 persons that access treatment for cocaine use disorder is a woman. 1 of 3 persons that access treatment for disorders related to pharmaceuticals or maybe over-the-counter treatments or prescription medication is a woman, and 1 of 4 persons that access treatment for alcohol use disorder is a woman. The other disaggregated data that I'll be looking at is the educational status of the treatment entrants. And 1 of 2 persons that access treatment for SUD on the continent of Africa have either completed only primary or secondary school education. While majority were unemployed, a sizable number, proportion of these individuals were students, and they are more likely to use substance than the individuals with part-time or full-time jobs. Then the referral to treatment. We have different sources of referral to treatment. The major referral to treatment is via family and friends. And we also have through work, employer, communities, and all. But it's important to note that we now have alternatives to incarceration. Following the 2016 United Nations General Assembly special session on the world drug problem, where our heads of state and government signed the outcome document and endorsed that outcome document to ensure that addiction or the use of substance is a public health issue and not individuals being incarcerated for using substances. We've seen a considerable changes in our judiciary system. So individuals with substance use disorders or maybe nabbed with a particular, we call it permissible level of quantities of substances, because beyond that permissible level, the person can be deemed as being a trafficker. And also these traffickers knows what is permissible and what is not permissible. So they tend to be nabbed with the lowest threshold of substances. And so below that permissible level, individuals are actually being referred from the criminal justice system to treatment. For the primary substance of treatment demand in Africa, it still remains cannabis. Is the leading substance for which individuals seek treatment in Africa. And these account for 39% of all SUD treatment, followed by heroin. We also have amphetamine type stimulants, which is not so much, tramadol, but this particular tramadol is not the 50 milligrams, 100 milligrams that is approved by the Essential Medicine or the International Narcotics Control Board. What we see is that the tramadol that is being used, over 500 milligrams, they are falsified and counterfeited tramadol with several mixtures. So it's beyond the permissible threshold. And then we have cocaine and others. For the others, we have prescription medication like petidine, methadone, also morphine, and then in some cases, cat. Cat is also homegrown, the way cannabis is homegrown in Africa. It contains cation and catenone, and cat was scheduled under the 1971 Convention of the United Nations. For cannabis, like I mentioned, it still remains illegal in Africa. It's not been legalized. I think 1 or 2 countries have already legalized the use of marijuana. And the reason is because we have tested the quantities of tetrahydrocannabinol that is found in most of the cannabis residue. The THC is above 50%, so the threshold is very high. And you can see the attendant results that we are seeing. People in treatment are actually majorly those that were exposed to the use of cannabis. This slide shows the innovative strategies that our youths are involved in substance abuse on the continent. Our youths on the continent of Africa, they call themselves science students. Science students because they mix and match different synthetics. And then when they mix and match, they come out with so many funny things, and it becomes their normal high. So when we are looking at addiction medicine, since yesterday we've been talking about conventional medicines, maybe we start to look at those drugs that are non-conventional but still have different addiction properties. The first example is kush, speedballs, bars, tornado, monkey tail, joint weed, cats, pot. So these are the different names they call different things. But of particular interest is kush. Kush has been declared a public health emergency in Sierra Leone and Liberia because we've had several hospitalized cases based on kush. Kush contains several things. It has cannabis with very high THC levels, as we've discussed. It has formaldehyde. It has fentanyl. And also, they exhume human bones and then crush and then mix it. So it gives this zombie reaction. The person stands up and is sleeping while standing, but the sleeping position is almost like an arc, whereby they can stay anywhere, and then if you watch this zombie apocalypse, or what's this called? Yeah, so something like that. So this is what the kush is about. Now the non-conventional drugs that I was talking about, which we have not actually been discussing here because actually non-conventional, and we just have, maybe if it's happening in Europe, it will be anecdotal evidence, is algae. I will not be explaining too much because I know we have a few youths here that likes to experiment, but they go to gutters, they scrape the green algae from gutters, and then they dry, and then it forms something that can be a normal high. We also have dung of wall gecko. I don't know if you know wall gecko, this thing that looks like a lizard. There's a whitish substance from the dung of the wall gecko that also can give another normal high. Urine, sometimes they store their urine for days. It becomes concentrated ammonia, and then, they can exhale that. We have, most of them exhume bones, and then they mix it with kush. And then also diapers. I don't know if, at least diapers is common. The baby diapers, is also very common. So these are the normal high. And I know we've been talking about different conventional drugs that is being used on the continent. However, how do we start when we're talking about methadone and buprenorphine or opioid? This is just way out of the conventional. Okay, thank you. And then to just mention that the 2024 World Drug Report that was released, people under the age of 25 years in Africa, about 31% of individuals in treatment were under the age 25. The next slide now will be talking about the survey so I have two different studies that I'll just brief us on. And the first one is on the survey of substance use disorder treatment and rehabilitation centers in West Africa. So what we did was to, following this report and the data and the statistics, we wanted to understand the types of treatments that our people that are into treatment for substance use disorders, what type of facilities are they going to, what type of treatment is available for them. And we studied the 15 ECOWAS member states. So ECOWAS is just one of the regional economic community in Africa. So we have different economic communities, and ECOWAS is one of them. So ECOWAS is just the economic community of West African states. As at the time of the survey, ECOWAS had 15 countries. The instrument was the WHO, UNODC, SOD, Substance Use Disorder Treatment Facility Survey. I saw Anya yesterday. She's part of the people that developed the survey. And yeah, so it was adopted for data collection in addition to different stakeholders consultation. And we did quantitative and qualitative analysis for that. So the objective of the survey was to assess the scope and quality of SUD treatment services across ECOWAS member states, to classify existing treatment facilities, to identify capacity gaps, resource requirements, and also to evaluate treatment modalities, in addition to developing a regional observatory. So out of the 15 ECOWAS member states, only 10 countries submitted their treatment data for analysis, and findings indicate significant variability in treatment capacity, with only 40% delivering evidence-based services. The bed capacity per facility ranged from 40 to 72. However, there are other facilities on in West Africa that have over 500 bed spaces, but unfortunately we didn't get responses from them. We're only able to analyze the reports that were submitted to us, and they all operate near full occupancy. Most facilities offered both outpatients and inpatients, but it's important to note that we have critical shortages of specialized personnel at these treatment centers. Based on the results, the classification of treatment facilities, about 35% of the facilities integrate both mental health and hospital-based residential treatment for their services, and only 8%, about 8%, 7.6% actually, offers specialized outpatient SUD treatment. Then the types of facility, we actually focused majorly on government-run facilities, and about 61% were public or government institutions for the survey. Then the types of services. From here, we can see almost 70% of the facility provide psychosocial support. And then there's a section there that has 7.7%. That 7.7% is actually the opioid agonist maintenance treatment on the continent of, on the regional data that we receive from West Africa. So only 7.7% of the facilities have methadone maintenance treatment or buprenorphine maintenance treatment. As per our culture and the type of embedded traditional, family-oriented traditional region or continent, because Africa is more family-oriented, where they focus mostly on family therapy and also group counseling. The other slide is just talking about the barriers to treatment, and majority of respondents indicated fear of stigma, not having enough information on where to go, or maybe the funding as part of the barriers for them to access treatment. Yeah, so after surveying West Africa, so let me start again. We started from the data on Africa and what is actually going on the continent of Africa, so that we can start to think globally. And then we moved to the treatment states and the facilities in West Africa. And now we want to go down to Nigeria specifically to understand the variation, if there's a variation in the attitude of mental health professionals towards tackling illicit drug use and drug-related disorders in Nigeria. And that's the map of Nigeria, but we surveyed the different 4 regions in Nigeria. We can see the northwest, northeast, southwest, and southern region. The objective was to assess the attitude of mental health professionals to see their role identity, and then to also understand possible regional variation in the attitude of the mental health professionals, because we were having reports of high dropouts rates from the mental health hospitals. So we conducted a quantitative cross-sectional survey, and in a randomized sample of 292 mental health professionals practicing in. So we have these federal neuropsychiatric hospitals and mental health hospitals. So very few countries have standalone SUD treatment centers. Rather, most of the SUD treatment centers are actually embedded in their mental health hospitals. And so we did a survey, and we conducted the survey in 4 geopolitical zones of the country. We have southwest, southern, northwest, and northeastern zones of the country. So we computed the sample size a priori, and we used ANOVA fixed effects, and then we also obtained ethical approval for the survey. So we had different subgroups of attitude survey, which was identified by the substance abuse attitude questionnaire, and we have 5 different categories. One is permissiveness, treatment intervention, non-stereotypic attitude, treatment optimism, and also non-moralism. Non-moralism, degree to which the respondents are not judgmental about a particular principle of conduct. So these were the survey that we conducted. So we actually used the Kruskal-Wallis test to assess the hypothetical variation, to understand if there were regional attitude from the different countries, from the different regions of the country. The reason why we conducted this non-parametric analysis was due to our attitude score, which violated the assumption of Shapiro-Wilks test for normality. And also we had a negatively skewed histogram that were plechotic. And then we conducted a rank-based Kruskal-Wallis analysis to determine the mental health professionals' attitude score from the 4 different geopolitical zones. So, and this was what we got. We got a significant Kruskal-Wallis analysis reflected that at least one of the regions that were surveyed had stochastically dominated other region. And because of that, we had to conduct a step-down analysis because we rejected the null hypothesis. So for the step-down analysis, revealed that the distribution of attitude score varies between the regions from South-South and Southern-West region, and also from the Northern Eastern and Southern Western region. So from the graph we can see, so when you move from a particular region to the other, you have different attitude, mostly judgmental, non-permissive attitude towards individuals in treatment for substance use disorders. It's expected that we have a standardized curriculum in the country, and that attitude towards the individuals that present with substance use disorder should be relatively equal. However, when you move from one region to the other, you will see less permissive attitude. It could also be in part that the northern region of the country, we have maybe the religious beliefs also, because our northern region of the country is dominated by Islamic religion, and they are non-permissive towards alcohol, talk less of drug use, while the other southern region of the country are less judgmental and less stereotypic. So the final result is that the attitudes of MHPs in Nigeria showed significant regional variation, and this reflected moralistic and non-permissive tendencies. And the step-down analysis also indicated different attitude disparities. Participants maintained a stereotypic principle. So for an example, the stereotypic principle is that majority agreed that individuals who smoke tobacco would eventually use hard drugs. So these are one of the stereotypic attitude, while those that indulge in the use of marijuana would not respect authority. So these are also part of the stereotypic attitude that emanated from the survey. So the findings underscored the need for harmonized regional policies, improved infrastructure, and capacity building to bridge the treatment gaps and also standardize SUD treatment and care from Nigeria, also cascading down to West Africa and to the entire continent of Africa. So now we have the Union of Africa, which I showed you initially, which is an intergovernmental organization of 55 countries. And they've come together also to see how we can actually effectively tackle the menace of substance use and the related disorders on the continent of Africa. So the overall objective, so we have this policy framework that guides our member states, and it's called the African Union Plan of Action on Drug Control and Crime Prevention. And the overall objective of this AU Plan of Action is to improve the health, security, socio-economic well-being of the citizens of Africa. It is anchored on 9 different pillars. However, we ensure that it followed a holistic and a balanced approach. We believe when there's no demand for a drug, there will be no supply. So we have this integrated approach. And also to mention that the plan of action also ensures availability of controlled substances for scientific and medical purposes while preventing its diversion. So these are the 9 priority pillars of the African Union Plan of Action, and I will not bore us with the different pillars, but it has the drug supply reduction section, the drug demand reduction, alternatives to incarceration, cross-cutting issues, to mention a few. Part of our response is actually effective prevention through sensitization, advocacy, with media, with traditional and religious leaders. We also have alternatives to incarceration, which I mentioned earlier. As part of our response, we have treatment, looking at effective treatment, and not just treatment, but reintegration and rehabilitation of individuals that abuse substances back into the society. We have recovery and care and evidence-based harm reduction program. These are just part of the key achievements that we have so far achieved on the continent of Africa. We've been able to establish the Sentinel surveillance system that is used to gather data. So when we understand the trends and statistics of what is going on in terms of data or drug use trends, we're able to inform policy better and to also have effective implementation and implementation strategies to reduce the menace of substance use disorder on the continent. We've had enhanced technical capacity. We collaborate with United Nations Office on Drug and Crime, Colombo Plan, International Narcotics Control Board for drug demand reduction, and we've trained over 6,000 professionals on the continent and still counting on universal prevention curriculum, universal treatment curriculum, and the universal recovery curriculum. We train competent authorities on accessibility and availability, and then we also have youth engagement in drug prevention program. Then we further incorporate traditional and religious leaders in drug use prevention, treatment, and care. And then we ensure that we integrate gender-sensitive and age-appropriate perspectives in our policies. For example, we have the Cairo Declaration on Addressing Drug Use and also the high-level Lusaka Declaration that was published about 2 years ago. Then we also have annual continental consultations and in-country public-private partnerships. Part of our achievement is also policy leadership and global engagement. We consistently represent the continent's priority in global drug policy fora like here. We've been part of the United Nations high-level session, Commission on Narcotic Drugs, to inform policy, and also participated at the United Nations General Assembly, where we lay bare the continental priorities when it comes to drug issues on the continent. And then before my final slide, is just the policy implication of all my presentation to ensure that we scale up evidence-based substance use prevention, treatment and care, rehabilitation and social integration in member states, and to also enhance age-appropriate and gender-sensitive drug use prevention programs on the continent. For the past 2 days, I know we've been here listening to different practices on the continent globally. I know we've listened to Canada, to US, and how their practices is informing evidence-based policies and all that. But it's also good that we are here so that we can think globally, thinking about the future of where addiction would be, and then to act locally effectively to ensure that we have a safer community. Thank you.
Thank you very much for this very comprehensive talk and amazing things that you're doing in the African region, and all that efforts that we can learn of in other contexts, in so-called North contexts. We usually think the things about coming from North to South, but there is a huge bunch of knowledge that we can have the other way around, and thank you very much for diving into that in your at the UN level. I've been head of WHO Collaborating Center, and having worked with UNODC and WHO on one tool which is aimed at capacity building for mental health, which is Treatment 2 and Mental Health Gap, and the joint efforts that have been done to build capacity of professionals, non-specialized professionals in all over the globe, including in the African region, to be able to deal with substance use disorders. There is a model specifically on that, and I know that is very helpful for African context, and thank you for having cited that. Thank you very much for all your efforts. We will take some questions. We have space for many questions, so please don't be shy and ask whatever you want to our fantastic speaker.
Thank you for providing us insights on the African context. Would harm reduction be an intervention that is widely accepted?
Thank you for the question. So, to start, Africa is saddled with different responsibilities. We have communicable diseases, so it will seem like a yes or no question, but it's far more than that.
No,
we have, yeah.
Just more like here in the Western countries, it's always a discussion between abstinence and
Yes.
is harm reduction acceptable? Yeah. And I just wondered how you would view on this issue.
Yes, so personally, yes, but like I was saying, the continent is saddled with different things. So we have communicable diseases, we have Lassa fever, we have Ebola, we have all these things going on, actually. So what we see in most of the continent of Africa is that the healthcare resources, that is not so much. We focus mainly on those infectious communicable diseases. Communicable, this one that you just touch someone and you're already having it, and then the infectious diseases, rather than the non-communicable diseases. Although we still focus on the other non-communicable disease, but mental health services are not very well funded, I would say, due to the stereotypic perspective that I mentioned. And the stereotypic perspective is that an individual has purchased the drug, you have used the drug, you have enjoyed the euphoria of the drug, and you want us to treat you, I think the treatment should come when we have sorted out A, B, C, D. So these are the challenges. So for harm reduction, most of the countries on the continent have been very selective. So what they've done is, in terms of maybe supervised needle exchange syringe system, supervised injection, needle exchange syringes might not really be there. We have very few countries now dispensing methadone and buprenorphine, but very, very few countries. So in the spectrum of the harm reduction services, about 12 or thereabouts, I think Africa on the continent, we are doing like maybe 3 or 4 of the services. So in general, we're still pushing for harm reduction services because of the public health importance and significance. Not too widely popular, but a step at a time we're getting there. Yeah, thank you.
Thank you very much.
Okay, thank you. My name is Rotimi Kolawole. I'm from Canada. Well, I'm from Nigeria originally too, so thank you for that presentation. I'm a public health and addiction medicine physician. I've been living in Canada for the past 15 years, double certified. So just want to thank you for highlighting some of the issues that have been going on in the continent of Africa that sometimes doesn't seem to filter to the world. And also clarifying that Africa is not just a country, but a continent with many countries. Considering that there are diversity in Africa, I mean, in terms of the governmental, the way different government works, what role is the African Union doing to coordinate some of the advocacy work which we have in some of the community-based organizations? I know there are different organizations doing some work for people with substance use disorder, faith-based organization, traditional organization. So how is the African Union coordinating that, those different work in such a way to decrease the use of these substances among the youth?
Thank you, Dr. Kalawole from Nigeria. Thank you for the excellent question also. Yes, the role of African Union, like I mentioned, we have the AU Plan of Action on Drug Control and Crime Prevention. So this plan of action, we ensure that member states develop and formulate their national drug control strategy aligned to the AU Plan of Action on Drug Control and Crime Prevention. And then in terms of sensitization and advocacy, and for member states to be able to key in, we have the statutory ministers meeting every 2 years. It takes place every 2 years. So here we are able to bring in experts from all over the continent to review the continental strategy on AU Plan of Action. We check the status of implementation, like in monitoring and evaluation, what part of the implementation of the framework needs to be reviewed to fall in tandem with the current realities and all that. And then following that, any resolution or the outcome document from the different meetings and advocacy is being forwarded to the heads of state and government. We hold our summits twice a year, and so this is where we present the resolutions and all that. For example, I would get the recommendation and outcome document from this ISAM web program conference, and then include it in the resolution for the African Union. And then our member states review these outcome documents, and then they propose it to the heads of states and government. So it's from like the top level cascading down. But we are able to have as much as possible the political buy-in that we require. However, beyond political buy-in, we realize that member states are also just ratifying and endorsing some of our protocols, but they are not domesticating and implementing. So we also go to member states to conduct monitoring and evaluation to understand the status, where they need help. We document this, and then we try to mobilize resources and to help such member states. Thank you.
Hi, yes, that was an excellent presentation. Excuse me, I'd still like to understand a bit better, perhaps regionally in Africa, the general drug trends. That is to say, if you're talking about the States, it's fentanyl and stimulants. 50% THC I hadn't heard of. I don't know who's breeding that. But for instance, what are the general drug trends? And if 30% is youth, who are the other people? Is a lot of it alcohol? How is it different by region? It's a big question, but at least generally, I'd love the feeling of it. Thank you.
Okay, so I have data on that also, but I felt I shouldn't bore us too much with so much statistics. But in terms of the trend, unlike the opioid crisis that we're experiencing in the US, particularly fentanyl, for the trend in Africa, like I mentioned, we start with cannabis. Although about 24 states in the US have already legalized the use of marijuana for recreational purposes, it still remains illegal in Africa, most of the African countries. We have only 2 countries, or 1, that have legalized the use of marijuana. And we're still following the United Nations Convention, as long as the UNODC Convention is still regulating the use of marijuana and being seen as illegal, then we still maintain that position on the African Union level. The other drug, it's
more like, is North Africa, is it also cannabis in the North African area? Is it the same thing in South Africa?
Oh, okay. So you wanted to see the regional variation in the types of substances that is being used. Yes, so I would say for cannabis, it's general on the continent of Africa because it's homegrown. We have the vegetation. People grow it at the back of their houses. It grows very well without nurturing. So, in fact, traditionally, some people include it as part of the vegetables that they eat. Some include it in their hair, for cosmetics, to beautify themselves. So traditionally, these have been the trends initially before the THC level being altered and all those United Nations Convention. So I would say that generally, marijuana or cannabis use is prevalent in on the entire continent. For heroin, we have very few countries like Guinea-Bissau, Cabo Verde. We have those countries that are around the coastal area. They use most of these substances. And the challenge is that the drugs are actually in transit to maybe Europe and to other countries or to other parts of the continent. So it's not, but the challenge we're having now, or let's say, because we now have enhanced intra and inter-agency collaboration and cooperation and real-time intelligence sharing, the traffickers are unable to proceed with the process of trafficking the drugs to other parts of the continent. So it remains in those countries. I mentioned Kush, and Kush is typically more popular in West Africa. And this is the combination of cannabis, fentanyl, formaldehyde, and different other combinations. So I think, and then we have prescription medication. Most of the prescription medications are readily available. So we have benzodiazepines, the morphines, and all that, which are really, although it's been scheduled, but we still having parallel importation on the continent. And so these are also being abused by the people. Thank you.
Thank you, Dr. Akinola.
Thank you, Professor.
Thank you, Dr. Akinola, for this excellent presentation. I'm from Egypt, and I know how African Union Office is helping most of African countries and more helping African countries to more engagement. And what about the addictive behaviors, Dr. Akinola? You know that for the last 5-6 years, we have the problematic use among adolescents, the problematic use of internet, gambling, social media, problematic use. Either any future interventions suggested from the African Union to the countries regarding the addictive behaviors problems?
Thank you, Professor. Thank you. Yes, so we, luckily, the Plan of Action on Drug Control and Crime Prevention from 2019 to 2025 is currently being reviewed. And so we are looking at these cross-cutting issues, the internet, gambling, and all that. We're also developing model law for online safety in our children. And so we'll be embedding all these cross-cutting issues to ensure that they are effectively tackled on the continent. Thank you. Do I have any more questions before I go back to Africa?
Yes, one last question before concluding. We have 5 minutes left.
So
yes,
I want to ask you about, hallucinogenic substances in Africa. Maybe you have some information about addiction, about cathinone using, real cathinone using in Africa, or ibogaine using, ibogaine addiction, or other substances, something like that.
Okay.
Thank you very much.
Thank you. So I'm aware of the use of cat, which I mentioned initially. So cat contains catine and cathinone, and is also homegrown in Africa, like cannabis. And so majority, we now have a surge of cat itself. The challenge sometimes is also to quantify what is being used, because most of the time is in the herbal form. The cat still remains in the herbal form, but has been scheduled under the United Nations 1971 convention, so it still remains illegal, but it's also popularly used. They just chew like normal medical medication, so you just cut it and chew because it's readily available. Yes, and we are looking at the addiction also in this part. Thank you. Yes. Can we have one more question?
Very last. Very last and
because
very short.
I have one question also.
One question. Thank you for an interesting talk. It sounds like a really big challenge, considering how big Africa is and all these problems you have. I was thinking about, in a way of prioritizing, because all these drugs you talk about, and then I hear about cannabis and about cat, and I think that maybe those are this endemic in all the countries, that maybe prioritization would make it much. Well, I wonder how you can tackle it, and I was thinking about the fentanyl, about the cocaine, about the opioids, which are imported into the countries. Isn't it supposed to be a bit more, not easier, but to aim on those drugs instead of on cannabis and on cat?
Yes, we're actually looking at everything. Unfortunately, my slides did not do justice to the data, because we're looking at the data on the entire continent, and we've been able to also have region-specific data. It's just that we're showcasing the global, not regional-specific, country-specific, context-specific data, but just having a quick global overview, continental overview of what is happening. We have different countries. Like I mentioned, Kush was declared public health emergency in Sierra Leone and Liberia. We were able to mobilize resources. So currently I work with the U.S. Department of State on international narcotic law enforcement agencies. We mobilize resources from them, from WHO, from United Nations Office on Drug and Crime, to ensure that this public health emergency is effectively tackled. There was a time Nigeria also declared codeine-containing cough syrup, which is the codeine itself, as a public health emergency, and they were able to move policy to that direction. So we look at country-specific, context-specific interventions when we are actually trying to move policy in the right direction to effectively tackle this. So not an umbrella, one-size-fits-all, just like my presentation has shown. It's just to have an idea of what is going on the continent. But we have country-specific, content-specific, disaggregated implementation strategies on the continent. Multi-sectoral, holistic, using intra- and inter-agency collaboration and cooperation. Thank you.
Thank you.
So
Your question, please.
Thank you. Yes, for the past 1.5 days or 2 days or thereabouts, we've been looking at the conventional drugs. And I know the world is a global village. And although we have different region-specific, continent-specific challenges, but the question will now be, when we start to see non-conventional individuals using substances, that has used substances and are now accessing SUD treatment, they have developed addiction on the non-conventional substances that have been used. What do we think will be the way out? This is us thinking globally and acting locally. Thank you.
Thank you very much. Just one concluding remark from me for this keynote. Just maybe what you said about addictive behaviors in the African region and the African continent. Yes, working in this area, indeed, there is a pre-assumption that we can have that dealing with addictive behaviors in such context would be losing efforts and losing investment rather than taking care of other so-called better, more priorities. But just to remind that there is no health without mental health, and that we should take care of our populations at a global level, in every context, for every gender, for every age. Thank you very much for being here with us, and please keep being so engaged with our speakers. Thank you very much.